Greetings from the Ramalingaswamy Center and welcome to our colloquium series on equity and social determinants of health. Thank you all for attending today, a week later than we were originally scheduled. So I appreciate the time that you've all taken to reschedule your attendance as well. So thank you to everyone who's here today. I'd like to welcome today Dr. Bhuvaneswari Sunil to give our talk. She's also known as Bhuvana and is a Mumbai resident originally from Tamil Nadu. In 2001, she completed her post-graduation in econometrics and has since been actively involved in various health research projects throughout the country. In 2018, she earned her PhD from the School of Health System Studies in Tata Institute of Social Studies in Mumbai. During the first decade of her professional journey, Bhuvana focused on tuberculosis and HIV research, collaborating with academic institutions in southern India. Subsequently, she transitioned to teaching economics and research methods at esteemed management colleges in Mumbai and Cochin. Since 2010, Bhuvana has predominantly worked in sexual and reproductive health, contributing through consulting, training, civil society engagement, and full-time positions. Presently, she serves as the Director of Research at ARMMAN and is poised to venture into a new domain focusing on child sexual abuse. We are thrilled to welcome you today. We are on a topic that we've actually not covered in our colloquium series so far. And from my conversations with you, I know that it's also a little bit cutting edge for you as well, right? So we are eager to hear your observations on the field and try to help us make sense of what mobile technologies means for the field of public health today. Thank you so much for joining us. For all of our attendees, I request you to put down your questions in the Q&A box, and we will pick them up for discussion at the end of Dr. Bhuvana's talk. Thank you so much. The floor is yours.
Thank you, Abha. Thank you so much. Good evening, all. Thank you for joining. And I really extend my gratitude to Dr. Abha for reaching out, and also to our ESTH for providing this opportunity in this platform to share my reflections. And also thank you for joining today and making a schedule in your calendar to accommodate this to hear to this talk. And I believe it's very essential for us to establish the context from which my perspectives are emerging. And I want to take you a moment to outline my journey, providing a backdrop that will help you contextualize the insights I'll be sharing today. So to start with, like my doctoral thesis at TES, Mumbai, it delved into the induced abortion experiences of 16 women from Tamil Nadu. And this exploration focused on the intricate intersections of sex, gender, body, and various other social determinants or dimensions that facilitated the decision process of induced abortion among these women. And employing a feminist phenomenological approach and a standpoint epistemology as methodological frameworks, alongside the feminist ethics of care approach, I examined their abortion experiences. So this talk has nothing to do about that. But this journey enriched my understanding on how social determinants shapes lives. And definitely the feminist gender theories provided a very fresh perspective, challenging a lot of conventional public health literature on abortion. Over time, these learnings have become kind of ingrained within me, influencing my approach to both my professional endeavors as well as my personal life, I should say. Over the past 3.5 years, my focus has been devoted to investigating and understanding the application of mobile health, basically the mobile-based health interventions or services within the realm of public health. And the aim of these mHealth interventions clearly have been to extend services to populations that are accessing from the public health institutions and or to bolster the capacities or the capabilities of the public healthcare workforce in bigger sense. And these learnings have been acquired. Whatever learnings that I've acquired in this process was immensely rewarding, and I'm really indebted to ARMMAN for providing such an invaluable experience in this journey. And ARMMAN is an Indian nonprofit that's dedicated to creating cost-effective tech-based solutions to reduce maternal and child mortality and morbidity. And during this period of at ARMMAN, I have spearheaded various research projects and also interacted with several individuals, including women from rural and urban India, several public health officials who are at various tiers of the public health system, several ASHA and E&M frontline healthcare workers in different states, and significant stakeholders from the tech and many other domains. Additionally, I have also served as a member secretary on an ethics board tasked with reviewing several research projects that were centered on mobile technologies primarily. So what I share today is deeply personal, and it has evolved from my interactions, reflections, and a certain amount of engagement with feminist theories, technological ethics, the public health principles, and also the evolving landscape of the digital policies on the market in itself. So I would like to caution you that, most of my contemplations lean towards the social science, public health aspects. I'm not or I don't consider myself as a tech person or have expertise to comment on the technical side of technology and its nitty-gritties primarily, basically. And most of, before I proceed to, go on, I want to tell you that most of the images that I have used in this slide presentation has been taken from the Google Image Bank. So I just thought I'll better say it. They're not from Arman's image bank or my own personal image bank. 1 second. Okay, 1 second. Okay, so over the next, I'm hoping another half an hour, I'll be delving into the, the kind of a surge of digital health that has really unfolded in the recent years. And then we kind of explore the landscape of mobile-based health services, generally referred to as mHealth interventions. And then we'll highlight the potential for innovation and growth for these mobile-based interventions. And then we could and you would, and I'll then scrutinize their value proposition with the unique context of India and more specifically to women, because my experience also is like working and trying to work with a lot of women for an mHealth, right? So that's where the focus would be also towards. And then I will dissect how gender and equity dynamics intersect with these interventions. It would shed light on the broader societal impact these mHealth interventions could wield. Although I've tried to put a separate slide on gender and equity, I think so even prior to that, you would realize when I'm talking that it's inevitable to not dissect it as we speak about most of these, aspects right from beginning. So as I navigate through this terrain, we will also take a brief detour to contrast the landscape of research in digital health with the traditional research realms, which even I was more familiar to 3.5 years ago. And this, in a way, this juxtaposition will offer insights into the evolving nature of inquiry and also the challenges that this domain poses to researchers. Finally, I leave you with some thought-provoking questions tailored for public health professionals, whether you are working in the digital space or with non-digital interventions. And these queries, the idea of these is the aim is to stimulate more dialogue and introspection, encouraging us to kind of reflect on the most effective paths forward. How can I say? Maybe in a collective pursuit of better health outcomes for the populations and the communities that we work with. So I'm hoping this next 30 minutes we'll be journeying together and exploring the dynamics and the realm where health and technology shall intersect. Okay, right. So I'm sure all of you have seen so many mobile applications, so many mobile apps and things emerging. I'm sure you have heard it here and there. Some of you may have used some of these applications, but some may not have ventured into that side. But over the past decade, if you see, we have witnessed a remarkable surge in the digitization of healthcare, making it as a promising as well as a very rapidly evolving industry. In the year 2022, the Indian digital healthcare industry had touched $372 billion. And by the year 2025, it is estimated to touch $612 billion. So you can do the maths there. So the growth of this sector, if you see, has been largely driven by large investments from existing corporate hospital chains and several entrants who are backed by the private equity investors also. And this transformation is evident in the continuous introduction of several health and wellness applications in the market. And these applications offer a range of features, including suggestions, information provision, reminders, monitoring tips, and various platforms and mediums are used, such as applications, video consultations. There are smart wearables we are aware of, and there are several more in the market to name them. So, and when you look at it within the realm of health systems management, there is a significant advancement which has been made with the adoption of electronic health records. There are e-prescriptions, there are voice-enabled digital prescriptions, and several other innovative technologies are every day being introduced in the market, and they are seamlessly being introduced and also being used, basically. And if you look at the these technologies, one could say that they have revolutionized virtual care delivery through telemedicine, remote diagnosis across the sectors in several non-communicable diseases like eye and healthcare, in the area of cardiac management, cancer management, several to name. These have been remarkable in its own way, expanding access to care and delivery. And if you see the eSanjeevani telemedicine platform, it stands out as a flagship national digital healthcare solution in the public health domain. And some of you working in the public health space may as well have interacted to see how it works. Definitely it did. I have seen few of them where it has definitely during the COVID and times has really expanded care in much better ways than we have imagined. Then if you look at patient education and awareness platforms, they are all categorized under mHealth services, and they represent another burgeoning field. Like these platforms, they again utilize short messaging services like SMS. There is integrated voice response technology. There's WhatsApp, and there are similar channels that promotes preventive healthcare practices among the targeted population of interest. And there is diverse content and online campaigns that are playing a pivotal role in enhancing our the health literacy, and they are kind of fostering a proactive health management across various digital and social media platforms. So furthermore, if we see the integration of enabling technologies, this is not my domain, but if you see such as big data, AI, artificial intelligence, machine learning, and there are several enterprise solutions that have further really enriched the digital healthcare landscape. And these kinds of technologies have brought forth capabilities such as data analytics, laboratory information management systems, digital radiology, several decision support tools to support the healthcare providers. And I'm just naming a few. There's so many more to list out if you get into this literature and the domain. And the Indian government has spearheaded various initiatives to propel digital healthcare forward, and it is exemplified by the National Digital Health Mission. And the aim of this mission is to establish a robust digital health ecosystem that encompasses electronic health records, telemedicine services, and health registries. And the goal is to enhance healthcare accessibility and quality nationwide. On a parallel note, the WHO, the World Health Organization, has outlined a global strategy for digital health to fortify health systems by leveraging digital health technology for a wide range of people, consumers, health professionals, the healthcare providers, and also the industry stakeholders. And these digital health solutions are tailored to be fit for purpose, ensuring that there is increased efficiency and inclusivity, even for those with limited access to digital technologies. Now, let's take the next few minutes to focus on technologies that are leveraged using mobile phones and innovations that are designed direct to beneficiaries, basically. Yeah. Okay, so some of this that I have put up here is just a sample, and it's maybe because like I have known them, so I have kind of know them a little better, so I have kind of put up these. But for instance, just to take your mobile phone Play Store, put the word Arogya, you will see so many listing of apps that are within the well-being and healthcare domain that you will come across, both public government apps and a lot of private apps that are being promoted and available in the market. So following the COVID-19 pandemic, most of you would have realized, there's no need for data to prove it, but generally you would have realized there has been a notable surge in smartphone adoption across India. And this is paralleled by the rise of direct to beneficiary innovations and interventions in healthcare. And when you look at direct to beneficiary, which is referred as D2B initiatives, a decade ago, if you see, there were several digital health interventions worldwide that disseminated information as small text messages. That's a beginning of these mHealth interventions. That's a SMS, reminders, and they were collectively categorized under the umbrella of IEC, Information, Education, and Communication. Subsequently, if you see when the technology advances, it's a fast changing world, the pace at which technology changes is unimaginable. It advanced with the integration of IVRS, that is the integrated voice response systems, which is akin to the automated voice calls we are all familiar from the banking or telecom providers. Like you pick up the call, you realize somebody which is a pre-recorded call you're answering, or you are using the keypads to respond to those queries and do those. So, and Kilkari, if you see, I've just put up a small logo for Kilkari. The green one is a Ministry of Health and Family Welfare's initiative. It operates as an IVRS-based health information service to offer guidance on antenatal and childcare to all those registered individuals in the reproductive child health portal or the registry. That is one. There is this Bol Behen that has been introduced, My Girl Effect, and it caters to queries from adolescent girls and young women regarding their general health and sexual well-being. It's a English bot. There is something called Visa. It's an again a D2B product that is it's a life coach, AI-enabled life coach that focuses on emotional and mental wellness. And during COVID, I'm sure you all must have utilized something called MyGov Corona Help Desk app, right? So that is a D2B product. So all this kind of further exemplifies the fusion of technology and healthcare, even in certain contemporary challenging situations like COVID, right? So personally, I've contributed to the design of some of the chatbot-based apps as part of a WhatsApp incubation project. And there's this platform called WhatsApp Business Platform. What you're using is an individual user, but there's also a WhatsApp Business Platform that is primarily intended. It's also used by the commercial sector, but it is also aimed to address and use the platform for social sector challenges. So in the next slide, I'll run you through how tech platforms and digital interventions that are intended directly to the beneficiaries or the audience are transforming. Right. Okay. So at the forefront of our, like whenever you're talking about how something is transforming or changing, then you latch on to what is, where there is problem, and before you go and say how that is adding on to the current, how it is transforming or addressing or responding as solutions to those problems. So in that sense, at the forefront of our healthcare challenges lies literally a daunting task, I would say, because I've worked and tried to do this, of equipping the frontline health workers to disseminate information on multiple diseases, not just one, and with consistent quality. You're asking them to do really a lot. And here I see that mHealth is emerging as a hope, as a solution. How it offers a solution to this predicament by enabling the delivery of uniform and high quality information across diverse population groups. So in fact, any meticulously crafted, well-designed mobile health program, it has the potential to tailor information provision based on the intricate interplay between, let's say, disease management and individual determinants such as age, literacy, let's say socioeconomic status, because there are so many prescriptions that if I have to do face-to-face, I might look at you or income strata before I prescribe something on, let's say, food advice, right? And similarly, the presence of multiple diseases. Again, quote unquote, a well-crafted mHealth solution, and a lot is dependent on the data quality, right? And the outreach strategies for these interventions are also intricately linked to users' access to technology, the telecom connectivity, and also, like, because a lot of smartphone-based apps use internet, the quality of internet availability as well as the quality as well as the availability. Let's say, for instance, there are population groups that have only access to a basic phone or a feature phone, or with a very poor internet availability. They may benefit from platforms such as SMS or IVRS-based technologies to access to where we can provide them information. Conversely, if you look at those who have access to a smartphone, they can receive interventions that are leveraged by multimedia features through various platforms like YouTube. There are several apps that you can come up with, WhatsApp, and definitely most of the interventions that are presented through smartphones, that the platforms that can be enabled in smartphones, their impact is manifold compared to IVR or SMS. One can relatively compare and say that. So now, I don't want to go on talking so very structured in a way, but I thought, like, how do I make this talk a little bit more engaging and not make it very saying and listening kind of? Of course, there's a lot of talking by me for the first few minutes. So let me run you through a kind of a story. So I'm going to do this enacting as a person asking questions and how the people in the field have reacted to several of the things. So primarily this conversation is something that you would mostly, after hearing, would break, okay, what is gender, what is equity, and how it is interplaying, right? So that's the idea. I hope I'm a very bad storyteller, but I'll try my best. So, so I go to the field, I ask someone, Didi, are you not listening to this call? I thought this is your number. What happened? Like, is this your number? I said, yeah, this number existed some time ago. But Nyasa, there is a new offer that came up and we changed the number, or somebody else says like, oh, kaam nahi kar raha tha, recharge nahi kiya tha. We didn't do the recharge and therefore that number is disconnected. So I've taken a new SIM. I have put the new SIM and I'm using it. Okay. So this is where it starts, right? Like, so this is a very unique Indian population's characteristics where there's a lot of reliance on prepaid mobile phones, use of SIM cards. And there is and these are coupled with the propensity to very frequently change the mobile numbers. So we are going to see a lot of such things and we will connect it a little later. So, and then now I go to a woman there and like another household, I'm like trying to understand, are you receiving calls? Do you know about something? And, like this. And then the person says like, Didi, I'm like, there's a lot of household work. I don't know when the call came. And she says like, I'm very busy cooking. There's animals to be taken care of. There is a elderly child that also I have to feed. So I didn't realize I was so busy. And these are like pre-recorded calls. It goes in a scheduled particular timing. And then I go to some other place and she says like, oh yeah, I'm listening to all these messages and it's wonderful. I'm like really getting to know a lot of new things. And then I slowly ask her like, okay, how frequently, how often, when do you listen? Yeah, whenever I get time, whenever I get to see those calls, I listen to them. Then I ask, how frequently? Do you hear it every week? When are you trying to? When did you last hear? Yeah, I heard it 2 months ago. She's been hearing, but not consistently, is what I understand from her. But she's definitely listening here and there, right? So we'll connect a lot of these stories later. Then I go to another household. I ask, like, the earlier woman that I met, she has her own mobile phone. It is with her, and she's being able. The first woman that I met, actually, it was a shared mobile phone, and now again I meet another woman. She has again it's a family phone. There's no more landlines, right? Like, but mobile phone has become shared mobile phones now. So everybody in the household, the mother-in-law, father-in-law, the sister-in-law, brother-in-law, everybody uses it, and children also use them. So like this woman says like, yeah, like I'm seeing her actually. She's a very young married woman and she's very young. She must be like in her 20s. And it's a rural area. And she's like saying like, I'm seeing her. Basically, there's a incoming phone call. I'm asking her. She's very close to it. In fact, like she could pick it up actually, that call. Like I'm asking her, you don't want to take the call? No, oh, mother-in-law or somebody, my sister-in-law will come and attend that call. So it's an indication to me saying that, I'm the daughter-in-law, newly married. That's not the domain that I'm supposed to interfere. So they will hear. And if it is a call exclusively for me, then I'll pick up the call, right? And now slowly I'm realizing like, I'm going to another house. I'm just observing, and I'm asking like, I'm just seeing the house and there is a phone call incoming. Okay. There's a child actually playing this mobile phone, with the mobile phone. Maybe it is a holiday. Must be the child must not be more than 4 or 5 years old, actually. It's playing. There's an incoming call. The child outrightly disconnected the call and continues playing, right? And then there's somebody who says like, yeah, and I ask, whose phone is this? And she says, ये मेरा ही phone है, but सब लोग इस्तेमाल करते हैं. Everybody uses this phone in the family. So what I understood is like access to phone, and when you're talking about mHealth, is all interconnected to these aspects and stories that I'm depicting. So then I kind of try to go in depth and I'm trying to understand, okay, what is the reach of my programs? What is the likely reach and how much? There is, of course, there are women who are having access to their own phones and they are picking up and listening. That's one story. But there are so many other stories emerging from this field. And then I say like, so a call comes in and it has like, there is only a number display. Like I'm asking like, will you pick up calls? No, pata nahi kahan. I don't know where these calls are coming from. Maybe it is these advertisement calls. They keep pestering, you see. So we don't pick up the calls, or we pick up the call and disconnect, because if we don't pick up the call, they'll keep on calling us. So we disconnect the calls. And there are women like who say like, there are women definitely who say that, there is no phone here inside the house. There are only 2 of us living in this house. And my husband takes the phone and goes. So when I speak to the men, like they say like, Appo, pata hai? Like, do you know there are some calls coming like this? They say, yeah, some men said, yes, of course, we are listening. We also go back and tell our wives, like, we heard about this. You should also do this kind of things and all that. But then when we ask some women, so it's your husband's number. So does he come and tell to you what you have, he has heard or something? Huh? So no, he has never come and told us. Sometime once he said, you should not give this child this food and you should give something else. But other than that, I have not heard him saying much other than that. Now moving on. So this is what is likely to happen if women have limited access to phones, or when there is no absolute access to phone, even if there's ownership of phone among women. So this is a kind of reality I'm projecting. I'm not saying that this is what is 100% happening out there, but these are multiple realities in which we are talking about mobile health interventions. So obviously there could be people who have literacy, who have limited literacy, irrespective of their education status. But you would have already understood, like if something is an intervention that's based on SMS or an IVRS based system, you can kind of figure out what it could mean. I don't have to go beyond that. Now let's see what is WhatsApp. So before I speak about WhatsApp, I'll give you a kind of edge, because like a lot of you might be aware about WhatsApp groups and individual WhatsApp personal communications that we all do on day-to-day basis. But you must have also seen recently in the last few years in WhatsApp, there's a lot of WhatsApp business messages coming in. Maybe you gave your number some time ago in an apparel shop, or maybe in your eyewear shop, and starting to receive messages in your WhatsApp, and you have an option to block them, or you continue receiving promotions and offers and everything, right? Apart from chatbots that you have yourself initiated to get into a conversation, maybe to procure milk or vegetables like Big Basket or something. But apart from that, you're also seeing that a lot of things you never asked for, but it is coming into your WhatsApp. So that's the WhatsApp business platform. So what is special with WhatsApp business platform and in a service provider perspective is that it supports multimedia content, making visual information accessible even to those with minimal literacy or even social media exposure per se. And even if women, they don't have access to a phone, or they may not be the mobile phone owners, but as long as they have access to their husband's phone or somebody's phone in which WhatsApp is available, then again, it kind of leverages in comparison to IVRS. And it also kind of gives provision to design user-centric design thinking into it to leverage, and it leverages it with the use of chatbots. And organizations can extend the reach of information services, and they can foster some kind of engagement with the user, individual users, even if it is on sensitive topics. Like, for example, Bol Behan is talking a lot about sexuality, contraception in English with his girls, which is very easily possible. And people open up because there's a kind of security when you're conversing in these platforms. Sometimes face-to-face counseling and all that deters people from approaching them, but this gives some kind of sense of comfort zone for people. So what I understand is that WhatsApp, if you see some of the images that I've put up, is that it gives these leeway. It kind of proposes that husband and wife can engage in a conversation based on an information you're sending. Women can access messages at convenience whenever they want. They can retrieve the information by downloading videos, because it privileges to send video formats of content, which is definitely engaging than sending text messages or somebody speaking out to them like prescriptively. And kind of in a context when you're talking about there's a need for engagement within the family, it definitely provides that scope. It helps to forward and build that attachment to these messages. And definitely it also, like if husbands are there, like they could also kind of look at these at their convenience and take it forward basically. So there are definitely several challenges that persist in deployment of mHealth solutions, and platforms like WhatsApp seems to be offering promising avenues for overcoming barriers to access and enhancing the delivery of essential health information to even underserved populations. We'll come to the kind of access we are talking to, numbers that we are looking at, and especially women in this context. And if there is continued innovation and user-centric design principles followed, there is a potential to harness these digital technologies to advance public health outcomes, as well as empower these communities and women. That's a possibility, basically, what we are talking about. Okay, I know I'm not a great storyteller, but that was an attempt. Thank you. So now I'll kind of tell you, I told you stories from the field, but somewhere, how do we connect it to the existing literature and move forward with that thought process, So that's the idea. So according to the existing literature, definitely WhatsApp has surpassed traditional SMS as the preferred messaging service among both the smartphone users and the feature phone users. And definitely it is suggesting, the literature is suggesting, and several surveys are suggesting that women are showing a particularly high frequency of WhatsApp usage, definitely. And moreover, women often utilize their phones not only for communication, but also for entertainment and information seeking activities, such as watching videos via WhatsApp, browsing YouTube, and engaging in other social media platforms. And if you look at the literature that is encompassing or underscores about Asia, including India, uh, it talks about the gender disparities that is grappling with the population, and especially in mobile phone ownership, right? And if you see the recent mobile gender gap report done by GSMA, it highlights that 81% of men in India own mobile phones, whereas 72% of women do own mobile phones. When they talk about the discrepancy in the ownership of smartphones, the same data shows that only 14% of Indian women owning smartphones compared to 37% of men. So just to parallelly compare this with the kind of studies I have engaged in the last few years, these are the numbers that I'm quoting are from multiple studies and from various states, in different states, like roughly my experience around working with 4 to 5 states actually. It shows that anywhere between 40 to 60% of the women are having access to their own phones. And if you look at the smartphone ownership, it is anywhere from 70 to 90% among this 40 to 60% we are talking about. So compared to the mobile gender gap report, the access to smartphone in the studies that I have done exclusively among women of childbearing age group, or even among the frontline workers like ASHAs, this is the kind of statistics that we are looking at, very close to the ownership numbers here and there. I'm saying 60 to 75, and GSMA is estimating it around anywhere like 72%. But smartphone ownership in most of the studies that I've done seems to be much higher, way higher than the GSMA report. So, and also if you see in terms of the access to WhatsApp among these women, that is around, like I said, 70 to 90% of them are using WhatsApp, and it is the most widely used social media platform, and it is closely followed by YouTube and Facebook, roughly. These are the three major social media platforms women in our country. It's not just urban. What I'm talking about is also, it's a very big rural India that I'm talking about, and it has, the sample included several women from SC, ST, OBC population groups, as long as they were reachable with mobile connectivity and the mobile numbers were right, we reached out to them. Of course, there is an exclusion we are talking about. We don't know the picture of the population that is deprived of network connectivity or telecom connectivity. But other than that, this is the numbers we are kind of talking about. And if you look at, again, the literature when talking about and understanding the gender inequity parameters, literature says very clearly there is a gendered nature of phone usage patterns and societal expectations surrounding it. When you're looking at the Indian literature, there are stereotypes and social norms such as purity for marriage, patrilocal exogamy, and avoiding reputational harm. I've sent my daughter to a newly married place. You have been using mobile phones till now, but now in your in-laws' house, don't touch the mobile phone. You will not own a mobile phone. That's kind of a reputational harm we are talking about. subservience, and caregiving prioritization. These are the features often that constrains women access to and usage of mobile phones. Even in the field stories, when I was sharing to you, these are some things that also came out there, right? And despite these, barriers, we are talking about how does smartphone access to women, or how does WhatsApp as a platform kind of become superior to any of this when I see is one, they are already being used extensively by women and the general population at large. Second, we have seen the WhatsApp features. And third, if you look at it, the WhatsApp, women's access to ownership of phones, I changed the definition of access instead of ownership to, let's say she's able to access the phone for 2 hours or 1 hour in a day, and or 2 to 3 hours in a week, anybody else's mobile phone and WhatsApp, then the access tremendously increases to around 90% among people who are having access to a phone, household level smartphone. So that's the drastic shift it shows when we are talking about access to technology. And that's where the evolving technologies are transforming access, I would say. So these findings, like I said, really underscore the potential of WhatsApp and similar platforms in bridging information gaps and empowering, women, even in the face of the prevailing societal norms and gender disparities in phone ownership. There's a lot to discuss, and there may be a lot of questions. We can catch them up at a later point. So while contemplating the role of mobile phones in digital health interventions, one of the fundamental questions is what constitutes true access to mobile phones, particularly for women, and how does it impact access to and outreach of information services? Like I said, there is a varying landscape. 30 to 40% with women have access to basic phones. 40 to 60% are having access to smartphones. Anywhere between 20 to 30% are lacking access altogether in any state or geography that you are looking at. And these belie the physical and logistical challenges that accompany mobile health interventions that we have discussed earlier, that I have spoken about earlier. And if you move on, one of the underlying assumption is that mobile phones inherently enhance access to healthcare and improve health outcomes. Whenever we are talking to donor communities, philanthropics, the government, this is one of the fundamental assumptions and propositions, basically. And furthermore, mobile health interventions are expected to positively influence gender dynamics, foster greater male participation in health communication. While mobile phones hold promise for women, potentially empowering them with access to information and increased agency within households and health institutions, there remains a troubling question. Could these interventions inadvertently reinforce existing power differentials? Could they disempower women and expose them to harm or violence? So I'll give you a little bit brief on what I'm trying to say, because I have used big sentences and kind of big words here. For example, let's call out, there's a lot of call out for addressing the social norms and gender stereotypes that impact behavior or health outcomes. And I look out for gender transformative. If I get into the LinkedIn, I see a lot of gender transformative approach being followed and promoted for today. And the whole idea is these interventions with this approach can enhance, let's say, family planning and contraceptive uptake, etc., etc. However, I want to point out the efficacy of any such interventions across diverse cultural contexts. We are talking about India, ages, educational backgrounds, literacy status. Education is different. Literacy of read and write is different for me when it comes to digital interventions. Let's say we are talking about maternal child health. What is the pregnancy status? Which gravida, or which pregnancy is it? All these, to a great extent, remains uncertain when you are defining a particular public health universal intervention that is targeted to a particular audience. So the challenge of targeting messages differently to women and men, especially regarding sensitive topics like sexuality within couples, it all persists due to the reliance on a single contact point, which is one mobile number. Because when you're tying up to a registry for public health interventions, if you understand the dynamics of communication, then obviously you can recognize one mobile number. I'm talking about changing social norms. So probably if I'm doing face-to-face, my engagement with husband would be different. My engagement with family would be different. My engagement with woman would be different. But trying to put it all together in one slot or one bucket is going to be really challenging. And also the quality and flexibility of data registries, which serve as the foundation for mHealth interventions, they again warrant introspection. For any user-centric program design, it necessitates consideration of data attributes such as literacy, age, etc., to enhance efficacy of these programs, reach and outreach, and acceptance, adoption, likability, everything that you can count in. And digital literacy emerges as a crucial aspect as far as interventions are concerned for ensuring safety and privacy. And it requires a lot of proactive efforts from the designers of programs or propagators of digital interventions to promote digital literacy and also address security concerns, which you don't find in many of the interventions that we come across. Doesn't matter whether it is private sector-led interventions or profit or non-profit or public health. A lot of this is still nascent and there's not much of cognizance or consideration taken into account. And there's extensive advocacy, which is very essential to amplify the outreach of these interventions, right? Like it's very essential to acknowledge that mHealth information programs may provide very valuable insights. It can help achieve the desired health outcomes, but it hinges on a multitude of factors, especially the health system availability and the quality of care provided at public health facilities. I can keep on giving very good information, keep disseminating, but if these factors are also not addressed and the converging factors really challenges an underlying hypothesis, and it kind of necessitates a comprehensive approach to digital health interventions, basically. I hope I'm trying to, you get what I'm trying to say. So these are kind of the unknowns, like basically at least I would say that I recognize it, but if you ask, everything has a solution? It's a kind of, there's way more to go for many of the digital interventions that we are talking about. I don't know, Abha, can you just come in and say how many minutes I've taken so far?
You've taken a little over 40 minutes, but I think there is, I think I see the questions here, and maybe if you just do a quick run through on the challenges, as I think a lot of our attendees probably are engaged in this kind of research or planning to get into it. A quick overview would be helpful, I think. Okay. So go ahead for a few more minutes, I think, on the challenges related to.
I think I'll skip this or we can come back, but I'll just very quickly try to put together some of these aspects, like whatever are the challenges in conducting research, because like one is, first of all, there are a very few ERBs and experts who can understand the nuances of implementing digital health interventions and provide, suggestions and inputs to enhance your research and ethically. So it's a lot of proactive efforts for people who are engaging in this field to define it. There's no ready-made handouts for things to do it. But I think it also depends on people publishing more of their challenges in encountering it. And in my experience, it has been a lot of struggle. I've done a lot of mistakes, I know, but every mistake has been made sure that it's not repeated in my successive pilots or successive research projects. But overall, it's a challenging field where many times there's a lot of uncertainty with the kind of research outcomes that you're expecting. See, for example, I'll tell you a very small example. Like I said, The mobile number is your only point of contact. You have not seen this person. You don't know who it is, but you get a kind of line list of data from the portal, and you are trying to reach out to measure your impact or seek feedback or something, right? First of all, most of you might be aware about the data quality issues with a lot of registries that we are talking about. I'll not go into that. But having said that, there's quite a possibility that you have a population base of 800, you estimated to reach, let's say 200, let's say 1,000, and you estimated to reach 2,000. You don't have any idea how many upon actually reaching you might end up reaching 200, or would you even reach 200 given the data quality constraints. Half the people may not pick up the call at all. Half the numbers maybe a certain proportion of the numbers you're calling may not be the right numbers, and maybe somebody else, the number has changed, or maybe has not received the intervention and not aware about the intervention, so you're not able to proceed with the survey, right? Like and then there is, let's say, a pre and a post. How many in a pre that you had reached to a telephonic survey can you reach at the end of the intervention? And again, I told you a family dynamics, right? Like, for instance, like these are something that I've done. Like it's very easy. Like when you're doing a face-to-face intervention, you say my target audience is women, so I'm going to interview women. But whereas in an mHealth intervention, maybe that phone number was the husband. So I'm calling up the husband. Probably the husband was the one receiving it and not necessarily the woman. So then how do I talk to the husband? Is my tool prepared for the husband or for the woman? Or like if there is a possibility to transfer the call to the woman, or there's an alternative number to reach, I can do it. And look at large scale interventions. This kind of challenge that I'm seeing like really is manifold when you have to involves agencies, because there is a problem. You have to translate your tools in multiple languages and dialects. You have to definitely recruit agencies that has the capacity to conduct these interviews. Most of this have to be mobile-based application in which data entry happens. It can't be pen paper, because then it gives more scope for biases and mistakes in data collection. And all this also means you cannot be very rigid and tight with quality of data collection. There are going to be compromises. There are going to be new problems that are arising in between. The whole informed consent process and ethics that we're talking about cannot be very full-fledged, replicated like the research that you're doing, because you're having, at best you can hold in a telephonic survey maybe a person for 15 minutes. Even that is very expecting for someone to engage that. So in that you take 2 minutes, you split it up. Technically, I would like to not have a very ideal lengthy tool. I would have to kind of really say what is that I want to do. And then I'm having this population which is like it could be a non-literate population. It challenges me to incorporate in a survey the best of best options to collect data, like such as maybe the best would be yes, no, don't know, rather than going for a 5 or 7 Likert scale or a 10 rating scale kind of things, because you do not know what kind of population you are reaching out to, mostly because it's only during the survey you're collecting your socio-demographic profile of many of them. And the whole informed consent process is consistent, and kind of you talk to them, you make them in simple words and explain you're doing it, and seek permission orally. So these are like kind of challenges. So sometimes I keep reflecting upon, some of the methods, like most of this is a very nascent phase, and it's very easy to do a well-tested face-to-face intervention, have a structured implementation to do the research activities as envisaged, vis-a-vis an implementation which involves multiple layers of selection criteria from beginning to end. You keep losing people, by then you reach the end phase of your implementation research. And how do you manage to, it's a lot of decision making to, on the one hand, as a researcher, ethically, like, why do I have to collect this information? But for sometimes for program sake, and because we don't have any other information, you engage, you ethically confront and you say like, no, it's okay to collect data because I want it for further processing and understanding, even though it may not be ethically 100% right to do that. And again, a lot of challenges comes in designing the sample size. I think that is one of my big questions also in the next slide. How do we really evolve with research ethics and research design that are very adaptive and has more flexibility than rather than rigidity to adapt research? As in, we're all familiar with qualitative research taking cycles of adaptations, right? We keep going back and forth and adapt. Here in digital health research, even in quantitative and qualitative, we often realize probably that kind of flexibility is more necessary given the kind of complexity and challenges one faces in designing these kinds of research. Again, if the goal of the interventions, for instance, is to reach the most vulnerable, compromised population, and if mobile health and the mobile number is the only source of contact for you to reach, especially if I have to do a survey across 4-5 states and have a sampling design that's spread across randomly picked up, face-to-face interventions become very challenging, and the most feasible option is often telephonic surveys, right? And when we are talking about impact evaluations, there's a lot of pressure and stress on impact evaluations, and it's often a very challenging space to do through these telephonic surveys, impact evaluation, without even for sure knowing how much of the you will get data, you will get a sense of data, but because these are not interventions where somebody went and delivered the counseling or the information, so there is a check mark. I know that there is intervention provided. Here in mHealth intervention, that's challenging. You really do not know until you pick up the call and you start talking to them, right? You're getting into a survey already mode. So I think these are some of the hardcore challenges that one faces. Again, the so-called gold standard methods of baseline, inline, or RCTs are definitely very challenging if you want to have implementation research that is very user-centric. Like until I go to the population, of course, there are designs that are available, alternative, maybe quasi-experimental designs might be the more effective way of conducting research. All I want to say is it's not perfectly like what you would do in a traditional research. There's a lot of brainstorming required, putting in logical thinking with an understanding of these field realities to design efficient sampling strategy or selection of participants and take it forward. And somebody has to be very adaptable and reflexive to the field realities that you will get to know only when you're in the field. So, or even if even in case of telephonic surveys and all that. So it's a evolving space, and we need more researchers and people to understand this. And as people start sharing their experience, possibly there could be more acceptable and other less dominant research methods that could be employed as good evidence for digital interventions, is all I want to say. Okay. I think I'm going to leave this for the audience to think through, basically. These are the big questions. The one thing I would like to really quickly and run through is, I'll not take more than 2 minutes, is, these are the pivotal questions. First is, to what extent can government mHealth interventions accommodate demand-driven services? So designing mHealth interventions, is it a one-time task? It requires ongoing review, user feedback mechanisms to be incorporated, and it requires frequent course corrections. So that's a point to be remembered. And women want answers that are not available to the health system. So particularly for large-scale interventions or nationwide interventions, it's very crucial to closely examine how language, dialect, socio-cultural factors and norms influence the effectiveness of these originally designed content and communication strategies for interventions. Because you'll always see the digital health intervention, the scope is to scale it up, right? Replicate them. So I think these are the very important points to really be able to provide demand-driven services, and that's where it is. Second is, at every state and numerous NCD departments, if you see, they're all exploring digital interventions. And the challenges lie in converging these efforts to alleviate the information overburden on individuals. And this convergence must occur at the levels of registries that we are talking about, platforms, information dissemination, designs and styles and modes, and also the communication channels. We keep talking about interoperability, but how interoperability in these matters, not just the data interoperability, but even the in convergence of these factors matter a lot. Thirdly, while digital, they are lauded literally for their cost effectiveness compared to physical interventions, and always these are spoken in terms of scales and numbers. And there is a pressing need to scrutinize the actual cost in sustaining and ensuring the optimal reach of these interventions. And much of the existing evidence that we are looking is small-scale pilots or controlled experiments, which is very easy to clearly control and have an idea. But in order to make sure there's enough information to make outreach of these interventions accessible, I'm sure there's a lot of cost involved in sustaining them or holding on, making sure these are available and accessible. I think failing to offer a comprehensive understanding of true cost of digital interventions is not fair, and we need more information and details on those as well. And lastly, there's a need to contemplate how the researching peer community can actively engage in research methods and design that focus on assessing the reach of digital interventions among the marginalized and the vulnerable population. We need probably very different strategies to really understand that. The generic designs, research designs, or the ideal designs may not be the best to answer these questions, especially for those with limited access to technology and constrained by other parameters. So by prioritizing inclusivity and equity in research endeavors, one can strive towards harnessing the full potential of digital health interventions to improve the health outcomes for all, or at least ensure that the alternative forms of dissemination strategies are available to these population without compromising their needs as well. I think so. I'll pause here and over to Abha. Thank you.
Oh, thank you. That was a very, very dense and complex talk, but you walked us through it, I think, in a very easy to understand manner. There's lots of points, I think, that we'll have to think about and reflect on. I think you raised issues that I hadn't even occurred to me. I think it probably occurs to you when you're in the field, as you said, right? So this was wonderful, and I think lots of food for thought for everyone who's attended today. Lots of potentials and pitfalls to mHealth, right? And to think about which direction we could go in and how we could harness it is a very challenging topic here. It feels like there's two main issues at play here, right? One is the value of mHealth technologies itself, how they can contribute to existing health systems and so on. And the other one is the equity issue. And thank you for bringing up both of those and sort of the challenges and ethics involved in both of those areas as well. I'm going to start with there's a couple of questions from the audience itself, and I request other attendees also to put it in as and when they occur to you, because I think there's a lot of thoughts here that are worth discussing. So we have one attendee who asks, what's your take on digital health products in the form of point of care and handheld screening and diagnostic devices? And he or she's given a few examples as well related to breast cancer, TB readings, cervical cancer screening. So how do you see these products making a difference in access to screening and diagnostic services for the underserved?
So I'm just going to ask you, like, I was looking through the chat box and I was reading on the reverse when you were saying, you just one more time repeat the question that you posed, please.
Oh, okay, sure. No, I think I think this is a question. It strikes us a lot of those of us in urban India as well, because I think we come in contact with it every day. And the potential, there's diagnostic centers at every corner, but I think this has the potential to do something for rural India as well. And I think our attendee is asking, what is your take on these kinds of digital health products like handheld screening and diagnostic devices for breast cancer, for TB, cervical cancer screening? How do you think these technologies might improve access to screening and diagnostic services for the underserved?
So a lot of public health initiatives that have been taking up these kinds of e-health services primarily, they are evolving. And if you see, those things are definitely increasing access to people who are in either in geographic areas that are compromised, or doesn't matter, like as long as it's a public health program, it's definitely being taken even into rural as well as remote areas. Most of these are mobile as well, or there's a good, as long as there are people come at least to the nearest center instead of going to tertiary care centers. And a lot of these solutions over the years, depending on the life course it has taken to evolve, are perfectioning to a great extent using the AI models. So what one needs to remember is, most of the AI models, it needs a lot of data to evolve, basically. So obviously, that's why I'm saying, what is the life course it has gone through a product when you're talking about? Depending on that, obviously, it is in the very initial phase, then you can expect there is less predictive ability for these models to reach a conclusion or be precision oriented, or with high precision, basically. But as the model evolves, what we see is it picks up precision. But it needs a lot of data to be able to feed. And the kind of people who are involved in designing these models, what extent they can incorporate into the design of these models the realities, the socio-economic realities, and the wide the differences in the complexities in the identification criteria that you're setting it into decision support, etc. So basically, the model is using some kind of decision tool support to give precision and predictions to you, right? And so I think that is one thing. So having said that, definitely access can improve to a great extent. But again, it's a lot of, as long as it's a public health system driven effort. So for instance, I worked in Telangana. I have seen them using a lot of these e-health based models being used in the laboratory information systems that has rapidly increased the speed at which processing happens, and it's a very bulk process. It will eventually become cost effective, but there'll always be small hiccups here and there that's being compromised. But given that it's already there, it's going to be there. There's no question. Eventually, as you move forward in the next 10 years, everywhere you're going to see the ingestion of technology across domains. Yeah.
I think, as you pointed out, I think the motivation behind the program is important, right?
Yeah.
And if you're motivated to sort of incorporate it into existing health systems and health interventions, then the potential to do good is there. But otherwise, it might just be an addition to the array of mHealth programs that are available. There are other questions, but I do have a follow-up on this one. I feel like a lot of these mHealth programs are focused for obvious reasons on screening and diagnostic services. But when the system itself is unable to keep up with the demand for services provided here with, so let's say you do a cervical cancer screening and you catch somebody in the early stages of early stages of cervical cancer, we still lack somehow the facilities to actually treat that woman on a regular basis and to follow up, right? And as you pointed out, there's a lot of potential for technologies to also aid in that aspect as well. But I still think there's a little bit of a gap, right? Do you think that's a bridgeable gap in the near future? Because I feel like this first half is moving much faster than the second half in a way.
True. I think that's also my concern about. So you can provide a lot of information, you can do amazing diagnostics. But I think when you visit the public healthcare system in India, I don't see there's enough investment happening in the domain of improving the infrastructure and availability of services. While on the one hand, the system is pushing for e-telemedicine and all that.
Right.
On the other hand, the availability of doctors at the PHCs and even first referral centers are not adequate. So the limitation of any of these services, for instance, is I can diagnose, I can treat to a certain extent, But for many of the preventable deaths and mortality, you need a healthcare facility available to transfer the patient immediately and be able to provide care. And I think that's a long way to go. And this gap is what really is concerning for a lot of us in the space, basically. A lot of the mHealth products and services that you're seeing driven by the private sector is mostly linked to the hospital chains and everything that you see. They are very big corporate affairs, I would call it, which is getting into this space and doing it. I think I don't have too much to give and take from that, except for learnings and looking for demonstrating technologies, etc. But when it comes to the public health system, definitely it's a concerning thing. Yes, I agree.
Thanks. I think this links to another question that we have from Rajalakshmi about whether you have any insights from the experience of frontline workers who've been using mHealth technologies in India. I think certainly we've seen a rise in interventions involving, tablets or, apps on phones for ASHAs and Anganwadi workers to collect data and so on. How would you say, and these are the intermediaries, right, not the end users, so to speak. How much do you think this has helped them or inhibited them in their work?
Right. I have worked with a program called Mobile Academy, which is intended as a refresher course for ASHAs on the initial lessons that they've done on the RCH, chapters, basically, chapters intended for them. So first thing to say is every single ASHA volunteer or worker that you have come across, I have seen that they're extremely happy and have this great sense of empowerment that they have done a digital based refresher course. And as simple as them answering a question following listening to a chapter, they feel extremely elated and a sense of empowerment and self-confidence in them. We know it. We want it to be more challenging. We may not know many things, but we are willing to learn. And for me, as well as the comprehension or how much they can use this, there is definitely a lot of scope. They want more information. Today there is a lot of change in the space, right? Like ASHAs, who most of them who came into this field were like 12, 15 years ago. There's very small percentage of ASHAs who have been imbibed in the system in the last 5 years. So most of them have knowledge from there and they have extensive field experience. Like I said, somewhere very, very, very minutely in the talk, people want to hear so many things that's not being addressed by the health system. Like I can give you an example, be it women. Ashas are very similar to women for me, except that they have a higher role and responsibility than what we are looking at the women population in general. So they want to go one step ahead. We don't want to be just that simple communication provider. We want to step up as Asha's doing more in the community. We are very well respected. Can you give us more information and empower us with that kind of? And just like any woman, Ashas are also very open to learning digital technologies. And so if you look at overall Ashas, I would in a gut way say you would find anywhere from 10 to 20% Ashas are very old, may not be very interested in digital interventions because they're like kind of, I'm close to my, offerings and I don't want to. But all those Ashas who are anywhere less than 45, they have a thirst for learning more. And they're very versatile with operating WhatsApp. And in fact, I think 75% of the health system works on WhatsApp now.
I think 75% of the world works on WhatsApp now.
Yeah, no, I'm saying even the coordination at that level of frontline workers and the health system works on WhatsApp.
Right.
I hope I answered her.
No, I think a lot of your answers are actually more, here's more things to think about, right? There's no conclusive evidence or answers for any of these, so but that's helpful to get us thinking in that direction. Ranjani asks, she remembers reading a paper by Milind Tambe and Arman on, using AI and ML to track missed calls. And are you using that for WhatsApp or in any other way, she's wondering?
Okay, as far as Arman, the paper that she is quoting, I was not directly involved in that work. It was another colleague of mine from Arman who was working closely. But to give a idea about what they were doing, so basically, the whole idea. This was an in-house program they were working with called mHealth, which is very similar to the Kilkari model that I was talking about. The idea is like when you're tracking all their listenership patterns, we know that at a certain point, they are going to drop out of your, intervention, basically from listening further. So what the AI prediction model they sat and they did is like identify those who are likely to drop out so that a small intervention for them by telling them maybe it's good for, they designed an intervention, a small intervention, so that the AI predicts who is likely to fall out. So the intervention enhances and sustains them in the program, basically. So yeah, they are also trying to do the same thing in Kilkari, where like I said, sustaining the population in mHealth programs. If it's a small intervention, it's okay. You just ask them to listen to 2 calls and you say, but let's say like a woman has to be addressed throughout her pregnancy, where a weekly call is designed, or till the child reaches 1 year of age, there is a weekly content to be delivered to them so that they are age specific, gestation specific, etc. Then how do you hold them for a longer period? So it requires an extensive efforts to sustain them in the program. And especially for scaled up nationwide, statewide programs, it's a lot. It cannot be sustained without very positively, you know, what do you say, trained health workforce that works with the population that you're looking at, the targeted beneficiaries. Yeah.
Well, I think that's about the last of the questions, but I think we'll be thinking about this, and I think this is the kind of topic which questions will arise as and when we think about it more and more. I really want to thank you so much. For me, this was a really good talk personally, because I think, like a lot of public health scientists, we have a healthy skepticism perhaps of the use of mHealth technologies, and the sense that it often replaces more basic and immediate care and direct care provision. And I think you showed us how there's a lot that is positive if it's used well, if it's designed well, if it's implemented well. There's a lot that can come out of it. For instance, one of the things that you said, which struck me as really interesting, you said that women don't necessarily have control of their phone, and the men do, and we know this, of course. But where the spin that you put on it, which is that this can lead to engagement, it can lead to conversations between the husband and wife. It might have the potential to do that rather than just belaboring the fact that the woman doesn't have access to the phone or that information. I think that was really a new way, I think a new lens to look at things, and one that I think we should apply as social scientists, even as we delve deeper into mHealth, whether in terms of the ethical implications of it or the practical ones as well. So thank you so much, Dr. Bhuvana. This was fantastic. Thank you for joining us today, even if it was a week later. I really appreciate that you took the time and effort to, you were committed to this, and I'm so glad for that. So thank you to all the attendees too for being here today. And we will put this up on YouTube once the video is edited, and it'll be available for future viewing. Thank you.
Thank you so much.